prevention, actually, and the relapse process and relapse prevention strategies. So I'm going to share my screen. All right, can everyone see that?
Yes, we can.
All right. So let me just change one thing. There we go. So this is really going to be a more clinically focused presentation. Sometimes we talk about a lot of research and numbers and data. This was really going to be and I realize I'm freezing up. This is going to be a clinically focused presentation. And I'm going to show some slides that I really will do presentations with patients. So we do all of our treatment in groups at the moment, still on video. So I'll sometimes show some of these slides to patients. So these are both tools that I use with working with clients as well as for education. Whoops. So one of the things I just wanted to raise right away is how do we assess relapse risk? And there are some tools out there to assess relapse risk. And I realized, Mitra, I forgot to send you one of the tools. So when Mitra sends out the wrap up at the end, I'll include a PDF of this tool. One of the tools is called Aware. And it is a relapse assessment tool, just as an example, and it's an evidence-based one based on Terence Gorski's information about relapse. So Terence Gorski is probably the grandfather of relapse prevention, and he's really one of the people who identified these 6 stages of recovery, and in doing so really identified transition, stabilization, and early recovery as the highest risk periods of recovery for relapse. And then, you know, middle, late, and maintenance. Certainly there's relapse risk, but it's really in the early stages when it's the greatest risk for relapse. So you can imagine when people are first coming into treatment. And I'll often ask the question of folks, you know, in recovery, what do you have to change? And the most common answer is everything. And when you think about having to change everything in your life, that is really overwhelming. And sometimes people need some time to try and change everything. And in that transition, there can be, you know, slip ups and difficulties with that transition. So the transition is really the move from active use into not using. And it all feels uncomfortable. It all feels new, including in the family situation. So families will describe it feeling very uncomfortable and like walking on eggshells. And then stabilization is really establishing that new normal of what it's going to be like. And obviously for our patients, we recommend peer recovery support as well as treatment. And establishing peer recovery support in treatment. So meeting people in group settings who are also going through similar things. And then early recovery is kind of once people get out of the first initial 90 days of sobriety and into that early recovery period. But the first 3 stages are the highest risk for relapse. And really the reason for that is that people's brains are adapting to life without substances, and everyone in here knows the impact of addiction on the prefrontal cortex. And specifically what that means is that people in early recovery and in that stabilization and transition phase have a lot of difficulty evaluating the value and probability of risk when it comes to relapse. And I love watching people move through these stages, because what you'll see is people's ability to in the moment weigh the consequences, say much more easily in early recovery than in that initial stabilization phase or in that transition phase, because they now can evaluate the value and probability of relapse. And so they can say, I know that if I use, it's very likely that, you know, that my kids will be mad at me, or that I'll have a problem at work, or that I'll get a, you know, positive drug screen, and that will have this kind of consequence. Whereas early on, people are just sort of trying to find their way, and it feels much more like almost like a life or death situation in the beginning versus really being able to establish a new normal and what that may look like. And while it may be uncomfortable, it feels much more doable than that transition period. We always want to consider the stages of change when we're evaluating relapse risk as well. Obviously, in defining relapse, someone has to have a period of abstinence to relapse. So by definition, if someone's, it's considered a relapse only if someone has had a period of abstinence. But where they are, people can have abstinence in any of these stages of change. So people can be sort of white knuckling it in pre-contemplation where they really don't think they have a problem, that somebody else thinks they have a problem, and they're trying not to use, but their motivation is a little bit shaky because they actually don't feel that they have a problem. And then you guys are probably familiar with Procrasta and DiClementi's stages of change. So as people move through these stages, the risk of relapse decreases. So if people have had a period of sobriety and they're in these early stages of pre-contemplation, contemplation, or preparation, the risk is much higher for relapse. And then the action and maintenance stages, it really decreases. And then I often talk with patients about what does relapse mean, and I talk with providers about what relapse means, as well as with family members. And when you talk with family members versus the person in recovery, it often means something really different. Family members are terrified of relapse, and they don't necessarily understand that it can be part of recovery. So if you work with families, often in education around that, it also doesn't mean that the person has abandoned motivation for recovery. It means something went wrong in the recovery process, and the goal is really to learn from that. Relapse can be brief or relapse can be extended for an extended period of time. And for people in recovery, there's often a tremendous amount of shame and guilt around relapse. And so helping them not be so judgmental of themselves can be part of that relapse kind of the treatment process that occurs after a recent relapse is really supporting them in the learning that can come out of a relapse. So I like to show this slide because it's an old study by McClellan done in 2000, where it was really highlighted that the relapse rates for substance use disorder are very similar to other chronic illnesses, even though there is often this misconception that everyone who has a substance use disorder relapses. It's just part of what everyone experiences. And in fact, not necessarily, but a majority of people do. It does vary a little bit depending on the substance. So this isn't broken down based on substance, but this is the relapse rate with treatment. So early warning signs of relapse are changes, and these changes can be subtle. And again, I'll talk with patients about identifying these for themselves. So changes in thinking, changes in behavior, changes in attitude and mood are kind of the primary areas that we begin to see changes. As treatment providers, sometimes we believe that we can see early warning signs before, and this is before the person ever picks up a substance. So these are like precursors to that. And family members will often notice some of these changes, and the person in early recovery may not notice some of these changes. So part of the relapse prevention process is identifying what these look like. And they're a little bit different for everybody. And so talking with someone about really identifying them for themselves and owning that so as to be able to prevent an actual relapse is the goal. I liked this visual because it really highlights that relapse is not an event, but a process. So I have had very common experience of saying, what was going on for you, before the relapse? And people say, nothing, I was completely fine. And then all of a sudden, I had a drink in my hand and it was all over and I don't know what happened. Well, it just means that we didn't do a very good job kind of digging into the early warning signs, because there is usually a trigger, often thoughts and behaviors and mood changes, and then a craving before the actual use. Now, people's awareness of this process varies. And again, relapse prevention is about increasing people's awareness of this process. The earlier people can identify the warning signs, the less likely it is that they will actually relapse. And that was really Terence Gorski's work, was developing all kinds of interventions to help people identify early warning signs for triggers and cravings. So these are kind of the general strategies, which you guys many of you probably teach to patients that you're working with, their clients, developing an awareness of warning signs and triggers, avoiding the 3 Ps, so people, places, and things where possible. It is not always possible. We know that many of our folks actually live with people actively using substances, and they do not have the option of not living with them because they don't have the financial resources to move, or for a variety of other reasons they can't control their environment. And so it's not always possible. And so then you have to develop a plan for dealing with the high-risk situation of living with someone who's actively using when you're trying not to. And then we sort of teach what is recovery thinking and what are recovery behaviors, and then practicing them. Because, as I said before, in recovery, you kind of have to change everything. You change environment, you change how you behave yourself, and the way that you think. So my favorite thinking change strategy is actually slogans. So whether it be slogans from traditional 12-step recovery like AA or NA, they are thinking changing tools, and they're brief and usually easy to remember. And usually we do multiple sessions on slogans. Again, and it's not that someone has to be, buy in full force to 12-step recovery for the slogans to be really, really helpful recovery tools and relapse prevention tools. And so we frame relapse as a learning opportunity that is not required. So sometimes it's a little bit tricky when we say relapse can be part of recovery. It doesn't have to be part of recovery, versus relapse is part of recovery. And so everybody's experience is a little bit different with relapse. It doesn't have to be a part of recovery, but it absolutely is an opportunity for learning. And I'll often kind of throw in some memes or some affirmations about not judging yourself following a relapse. So this is just one example, that there's no shame in beginning again, where you get a chance to build bigger and better before. So again, framing a relapse as an opportunity for learning. And this is just a visual that I like, although I wish it had multiple exit ramps, but I couldn't find one with multiple exit ramps. So we talk about that there are lots of opportunities to get off the road to relapse before you actually pick up. And again, that idea that relapse is a process and not an event. And there are all kinds of exit ramps. So an exit ramp that I would give as an example would be to call your sponsor before you actually pick up, or to go to a meeting, or to remove yourself from the situation, or call any supportive person, or to read recovery literature, or engage in meditation. I mean, those would all be examples of potential exit ramps. There are some really common risk factors, and some people will resonate with these. I would say, when you ask someone, what is your what is your most likely relapse trigger? Everybody will say stress. So like, what is stress exactly? That's going to look really different for different people. But stress is sort of the most common thing that people identify. And then these other ones are also pretty common. Interestingly, positive moods is a common one. Summer, so seasons, is a common one because we know that substance use can also be very associative. So whether it be associated with events or things that happen during certain times of the year, or positive mood. So one of the things in recovery is we often try and help people learn how to celebrate. How do you celebrate without substances? And so that's why, the association of positive moods is usually about, celebration or reward when someone's in a positive mood, and finding other ways to celebrate or reward yourself when good things happen. Pain is clearly one, especially for those who struggle with opioid use disorder. And some of these other ones are pretty common. And so people, again, can identify which ones of these might be their top three. And then really what can be learned from a relapse. So when people report a relapse, and you guys probably know, I work with a lot of pregnant women with substance use disorder. So especially for pregnant women, reporting a relapse in a group setting usually is a pretty difficult situation, because not only are they relapsing, but they're affecting their unborn child and their fear of judgment, and they're likely judging themselves. What's wrong with me? I'm pregnant. I can't even stop using substances, and I'm pregnant. Don't I love my baby? Like all of that kind of stuff that's swirling around in their head. And what I typically say is, well, just because you're pregnant does not mean that your addiction stops. Your addiction is just as strong as before you were pregnant. And so relapse can be, part of people's experience as they're on their recovery journey. And so we talk about what can be learned. A useful tool, and this is borrowed from dialectical behavioral therapy, is a chain analysis. So it's borrowed from CBT also, is where you sort of identify these early warning signs that people may not have been aware of prior to them picking up the substance. So did they have an emotional vulnerability, a physical vulnerability? Was there a trigger? So these are kind of links in that chain that led to relapse. And then there's the sort of choice, the crossroads where they can go towards active use or away from active use, and the kinds of behaviors and thinking that occur when the person goes on the road towards active use and relapse, versus the responsive behaviors that can prevent relapse. And really articulating these. So this is a very kind of cognitive behavioral approach towards relapse prevention. And the important thing is, when we literally like do this in group, or we do this in individual therapy, is really to have absolutely, as the provider, like no shame, no judgment. This is very objective. It's an objective process. This isn't about, because sometimes patients don't want to do that because they feel like you're ganging up on them or you're beating up on them. And it's like, no, this is just like almost like putting something under the microscope and looking at it for the purposes of learning, not for the purposes of a negative consequence, right? People have plenty of negative consequences from the relapse. We don't need to create that in the therapeutic process. This is just about, how do you want to do it differently next time? What can we learn from this that might inform your skills to be able to do it differently next time? And then, some steps that people can take after relapse. Certainly acting immediately, and that's often getting honest as quickly as possible and letting safe people, whether that's family members or supportive friends, know about the relapse, as well as treatment providers. So that's why being honest is so important. If people are not honest about their relapse, the relapse is more likely to last longer, or perhaps they might have another relapse if they're not honest about it. So part of that getting honest is taking responsibility, using social supports, fellowship supports, and taking recovery actions. And so can look, people need to identify that for themselves, what that's going to look like. What is a recovery action? Sometimes that may be ownership of a behavior that they may have engaged in while they were using that they regret, or sometimes it may just be being honest. managing any after effects. So I've known far too many people who one of the consequences of a relapse was an arrest. And so often there can be, even though the relapse didn't last very long, there can be a tremendously significant fallout from relapse, and managing those effects can take many months because the effects were significant. So the timeline that managing those effects can take varies. Seeking professional help or returning to professional help if people have kind of gotten away from that can be part of the steps, and then really ultimately learning from the experience. So one of the things I do in group is I'll ask people to list their specific relapse prevention strategies. And this is a list that has come, basically from individuals that I've worked with. These are all the things that they've identified. And I know this is pretty small, and this is not an exhaustive list. This is just many of the things that people identify. So I'll highlight a few of them. One of my favorite ones that you guys may have heard of is HALT. So HALT stands for hungry, angry, lonely, and tired. And these are really vulnerabilities to relapse. So if you are hungry, if you're angry, if you're lonely, or if you're tired, those are all vulnerabilities in and of themselves. And if you have more than one, then your vulnerability is increased that much more. And so I think depending on the person's resources, some of these are pretty easy to address. So if you have access to food, dealing with hunger is usually one of the easier ones, as long as people have access to relatively healthy foods. It is really interesting that addressing these when people are in the craving stage before they've actually picked up is really effective. And the number of people that have certainly talked about, if I'm having a really intense craving to use and I actually, drink something or eat something, the craving decreases. So just the act of drinking and eating and filling up a little bit can make the craving go away, as well as removing themselves from an environment, changing their environment, going inside if you're outside, or going outside if you're inside, or taking a shower, like engaging in a physical activity. So that's one of my favorites. And does anyone else have? Can you guys read this? Okay, can you guys see this list? All right. So I was going to ask you guys if you had any good ones to add to the relapse prevention strategy list.
I'd recommend playing the tape through.
And do you want to share what you mean by that?
It's also called think through the drink. So you think, where does this life lead me? Where am I headed by using, and how can that help me prevent a relapse?
Absolutely, playing the tape all the way through, and that's really consequential thinking, and that's super helpful. Thank you. Any other ones that people use or that patients have shared with them?
This is also for just about any psych illness, but I like to tell people to do the reverse golden rule. So it's like, do unto yourself as you would do to somebody that you care about. So if it was your best friend, what would you advise them to do? Or would you want to see them struggling? So kind of the reverse golden rule, do unto yourself.
Yeah, and I think that's a great example for people who struggle with addiction, because oftentimes they have a lot of compassion for other people and not a lot of compassion for themselves. And so it's easier to think about how you might, take care of someone else, what you might, the advice you might give someone else than yourself. So that's, yeah, another good one. And sometimes if you do this as a group exercise, it can really build self-efficacy. So it's almost like the power of the group to come up with as many relapse prevention strategies as they can. And then people can, when we used to meet in person, we used to like develop the list, and then I would write them all down. And the next week I would bring in the list that they had created and hand it back out to all of them. And it was their list. And then they could help each other along the way and remind one another of the strategies they themselves had come up with. So in terms of resources, Terence Gorski is, again, kind of the most well-known relapse prevention specialist, and he has a model of recovery and relapse prevention, and it can be found at this website, which has a lot of resources on it. And it's really a model that is well suited for interdisciplinary kind of treatment teams, which many of us work on, and it's also pretty accessible to patients. So I encourage people to check out that website. And then in terms of books or resources, there's a second edition of Mindfulness-Based Relapse Prevention that just came out recently. There was a first edition that we'd used in some research here. And this is the second edition, which is great. And then Gorski has a workbook for patients, which can be a helpful resource. And then there's a evidence-based relapse prevention guide for therapists. That's a really good research. That's a really good resource. So any of those books can be found on Amazon. And then this is the quote I share with patients that they love this. So this is an English quote, which is why tires are spelled that way. And this is the one they like the best, because it somehow is like, duh, somehow this helps with a little bit of insight. And it goes, giving up on your goal because of one setback is like slashing your other 3 tires because you got a flat. Don't give up and repair. And this really conveys the message I try and talk with people about when there's a relapse is, you have additional resources. This is just one thing that went wrong. And you don't want to throw it all away just because of one setback. And the idea is to learn from it and repair. So any thoughts or questions or examples that you guys want to share about relapse prevention and how you help clients?
Thank you so much, Laura. You always do a wonderful job presenting and always have great resources as well. Yeah, any questions? I don't want to cut anyone off, so please unmute if you have any questions.
Laura, do you use the language of slip versus a relapse? Are you familiar with that, or do you use that?
Yeah, I mean, oftentimes a slip will be, the language of slip will be used as if something is very brief and people get right back on track, and it feels less harsh, right? Is I think why the language of slip is helpful. So and the reality is we are actually entering into a phase in terms of non-stigmatizing language where we're not supposed to use the word relapse. Does anyone know what the new word we're supposed to use is?
Treatment attempt.
Well, yeah, when people are kind of moving in between treatments, like if they're moving one and then they kind of go back to using, and then they come back into treatment. So return to use is what I've been told is the non-stigmatizing language that we're supposed to use. But again, to your point, Jeremy, like return to use is very different than slip, and return to use really implies a more extended period of time using. And so I struggle a little bit with return to use, because to me that implies that you're kind of back using for more than just an isolated incident. So yeah, I think slip is certainly appropriate to use for a very brief occurrence. Or recurrence is the other word that people talk about, recurrence of use.
And Laura, I saw the other Laura also chatted in saying we use lapse versus relapse, and she had also heard return to use as well. So Laura Simmons, I didn't know if you wanted to expand on that, or maybe what you've heard.
Can you see me now?
Yes.
I was struggling there earlier. We just like lapse versus relapse because relapse feels like it's a return to the complete old lifestyle, where lapse is kind of like just hit a little pothole instead of drove over the cliff. I don't know. That's how we look at it. But I've also heard the return to use. I'm not crazy about it either, but I don't know what training I was in, but that's a term that I know is recommended.
Yeah, and I think language that helps people get back on track without a lot of judgment is always helpful. So slip or lapse kind of seem to help with that.
We've had good feedback, from patients that are struggling. We've had good feedback with the terminology of lapse.
Yeah, and the main thing is really, for me, the most important thing is framing it as a learning opportunity.
And temporary.
Yes, and temporary, right.
Yeah, it is good to reframe it that way. And I would always kind of just use the language that they use. And if they come in and say relapse or slip up, then we would, go forward with that verbiage. But I always kind of go back over with them pretty much constantly of how to look at the relapse and using the right F word. I always say it's either a fumble or an F up. And, with a fumble, you can pick the ball back up and keep going. But if you look at it like you just F'd up, then you're going to feel like an F up, and it's going to probably perpetuate. So looking at it like something to learn from is always better, regardless of what terminology you use.
Yeah, I like the fumble metaphor. That's a good one.
Is there a ranking of relapse prevention techniques? Like what's the most powerful technique? Powerful technique, or
Corporal punishment is always better.
I'm just interested. Has there been a literature about that, or?
So, I mean, Terence Gorski has the most research behind his model. So, and he has really evolved. So, I mean, Terence Gorski has been around a long time. So what I put in the chat, or not in the chat, which was on that slide. So his CNAPS model continues to evolve as and integrate new evidence. So that's the one that I'm most familiar with that has the most evidence base. But if people have other models that they use or that they're aware of, happy to have people share those.
Real quick, Laura, speak on the phenomenon, because I don't think I experienced this before in IOP. So when people actually get upset if you don't overreact to their relapse, it's kind of an interesting idea. No, so I think people are used to, like, if they relapse, like people getting extremely upset and like, you blew it and blah, blah, blah. And instead, again, framing it like, okay, we can move on from it. But some people don't respond well to that. They're almost like expecting you to treat them like they've been treated their whole lives. So what are your thoughts on that? It's kind of.
Yeah, so Jeremy and I had this experience, or Jeremy had this experience with a patient in our IOP that relapsed and really wanted to be punished, right? I mean, it was almost as if she wanted Jeremy to yell at her or something, like she wanted a much harsher reaction. So, I mean, I would say with that individual in mind, often, for people who come from backgrounds where they have a lot of trauma and they're used to a very punitive kind of parental hierarchy, that was what she expected. And I do think she sort of viewed the physician prescriber as an authority and was looking or expecting to be punished, and wasn't quite sure what to do when it didn't happen. Like, does that mean it wasn't really a problem? Does that mean he doesn't care about me? Because oftentimes in abusive, family situations, the way that parents show they care is using corporal punishment or very harsh punishment. I actually think that was what was going on for her. And it's And it's okay for us to help people maybe expect a different response, or be okay with a different response, including an internal one that isn't about you're a bad person, you're a failure, you can't do this, you'll never amount to anything. I mean, that's sort of the harsh parental voice that sometimes is reprimanding people when they do have a relapse or recurrence. Any other thoughts or examples of how folks have helped people with relapse prevention?
I have found myself just naturally thanking people for letting us know. I did that from the beginning of working in the program, because that's a big part of it, is being able to be honest. And I do appreciate it. And the other thing, and I was just thinking about this because this wouldn't be appropriate for somebody who had a relapse after, I think, a really long period of sobriety, but a lot of the people I'm working with are struggling with frequent relapse. I'm working with our under 90-day group. And I don't know if this is true or not. You hear these things quoted, but I've heard this as attributed to Buddhism, this expression, fall down 7 times, get up 8. And people seem to like that. Just like, okay, well, okay. It happened again. Okay, get up,
Yeah, so 2 points there that you make. So I think validating how hard it is to, especially in a group setting, admit to a relapse is, I think, really important. And acknowledging that, being honest is not easy. Being honest is new, kind of new for people who have been in active addiction, especially if it's often, in settings where they had to lie about their use in order to protect it. And so it's engaging in a recovery behavior, certainly being honest. And yeah, so fall down 7, get up 8, that there's always another opportunity to get up. And that really helps kind of instill hope that there's no relapse that's too many, right? Because there's always that, except obviously if you die. So there's always that opportunity to get up if you're still with us. I like that. So do we have a case today, Mitra?
We didn't get a case submitted, no. So that is.
Does everyone have like a spur of the
We have-
moment relapse case they want to talk
Informal
about?
case, we always encourage it.
Or if anyone's been, because sometimes, as Jennifer was saying, people struggle with kind of chronically relapse, and it feels like they get up and they're still on their knees, and then they're back down again, so they never kind of get all the way up. And I don't know if people have any kind of examples of folks they've worked with who've struggled with relapse.
Yeah, I have an example. And I'm not sure what else we could have done. And I would love you all's feedback. So we had a lady, she had previously been in our program maybe about 1.5 years ago prior to COVID. And the first one she was in, she struggled for like maybe a few months, but then did well for like maybe six months or so. Then she stopped coming to the program, more so because she had issues with Crohn's disease and pain, and had to go back on opioids with the doctor. But in the meantime, she had struggled with benzodiazepines as well as opioids. She came back to us to enter the program. Now, the problem we had was that she was getting benzos from her family doctor. And what we did, we gave her a choice. She said, well, if you're on Suboxone, you're having intermittent seizures, that's another thing. I said, it could be related to a Xanax withdrawal. We really want you to talk to your doctor about maybe tapering off the Xanax because I can't keep you on both of them because of the risk. So she said she would. I told her it was difficult for her. I could reach out to her doctor, but she never had that conversation. And she continued to relapse to benzodiazepines and opioids. What was worse, inside the meetings when we had asked people how they're doing, she would always deny it. And so we were like, so I would call her afterwards and talk about it and say, hey, in our program, we're not concerned as much about relapse and more the behavior. And one of the best things to do in early recovery is to be honest so we can help. And we'd appreciate her honesty, so we can help her. But she continued to do that. In the meantime, she continued to have these seizures, which I'm pretty sure is related to her overusing Xanax. And so in the end, I had to offer her a 30-day dismissal or inpatient treatment. And she refused both. But in group, we talked about it. So I brought it up in group. I said, as part of this program, unless you have a medical necessity for Neurontin or benzos, it's our policy not to use those drugs. Everyone know that. Everyone's like, yeah, we know. And so we talked about her. I was like, so you want to, I brought her up. I say, you've been telling us that you're not relapsing yet. Your urine drug screen is positive. What do you think about that? What are your thoughts? And then she got very offended. She got really upset. She didn't say anything in group. She just said, yeah, I should have talked to my doctor about it. And I should do this. But for now, I think I want to be in a benzo. I don't want to tell my doctor. I think I'll come off Suboxone. But unfortunately, and then afterwards she called, she was very offended. We brought up her relapsing group. I'm like, hey, but you signed the treatment. And as a part of our treatment, we do disclose in group. I said, and she was like, well, I'm the only one you talked to it. I'm like, because in this group, you're the only one who relapsed. And I don't think she knew that. I think maybe she didn't realize she was in a group of people who were well into recovery. And the 1 or 2 people who relapsed, they did admit it. But I actually felt bad. I was like, man, is there anything I could have done differently or prevented or said to help her in her progress? But surprisingly, she called back the next week, wanted to come back into group, which I was surprised about because I thought she was really pissed off at me. But so I would love you all's feedback and tell me what I could have done differently.
So I'll turn it over to the group. Any kind of thoughts from the group? There's a lot of knowledge and wisdom in the group.
I like Mark Gallanter's approach to people who are using substances that they're getting from a physician. What he does is make an agreement with the patient to write a letter together to the prescribing physician saying, hey, this is not good for me. I have a bit of an addiction problem and I can't be taking medications that are habit forming. Please don't prescribe it for me any longer. And so to actually write a letter and send a letter together.
I like that.
Yeah, so that's like a collaborative process where there's accountability and it's actually happening. And
now, what if they said no? Because what I'd offer her was we have a group discussion with her family doctor. So what's the next step?
One thing to do is to get family involved, do network therapy and get some sober people that are connected to her to say, look, obviously something is out of control here, and get some input from the family to kind of create a little leverage.
Yep, we tried to do that to get her daughter and her husband involved because they knew about her recovery. And she refused because at that time, she and her husband were going through a bad time. And if she relapsed, he was going to leave her. So she was kind of in a bind,
Dean, a couple of things is, was she Medicaid? Because normally they won't fill both under the insurance, like they'll block it. So I'm kind of surprised that they would fill both. Was she a private patient or was she CAID?
I think she was private because we got sub-solved for her. And I know Medicaid usually gives us a problem for that.
Yeah. Okay. So yeah, that normally, like right off the bat, that you can use that as leverage if they're CAID, but obviously it's a little trickier with private. I have mixed feelings about discharging people based on benzo or alcohol use because the evidence is so much in favor of just keeping people on it, even though it is a little risky, not necessarily having them in coat. So I don't know. I have very mixed sort of feelings about cutting people off of Suboxone because it's such a risky time. So.
Oh, I'm glad you said that. See, because I was so worried about her because she kept having these seizures and she refused to let us get involved and talk to her doctors. And I knew her withdrawal seizures from Xanax. And since she didn't give me the permission, I felt like, well, man, if I keep giving her Suboxone and overdoing the benzos, I was sore.
The other thing is, I mean, is it withdrawal seizures, or does this lady actually have a seizure disorder and she's on benzos to help with it? I don't know. It's and so sometimes like going at it that way is like an intrigue, like you know, are you having these because you're using all your benzos or something else? Like you actually should take a seizure medicine, for example. Like you know, why are you taking this? Could you?
Yeah, she was actually on Keppra, and her neurologist had told her not to use benzos.
Okay, that's strange. But only Keppra. That's interesting. So the family doctor clearly wasn't checking her board of pharmacy either. So
No.
yeah, gosh. Yeah, I don't know. It's tricky. It's tricky. So I don't see why it would provoke a seizure though, unless again she was taking it and would stop it suddenly. But by itself, I mean, theoretically she'd been helping the seizures. So tricky, but I don't know, maybe offer something like Depakote or something like, why are you taking this benzo? Are you just trying to calm down? You know, here's an alternative.
And the thing is, what made me so worried is because she had an established mental benzodiazepine use disorder in the past, and she had gone up to like, I think she was on Ativan before and been up to 5 milligrams, and she got herself off of that. But her new doctor didn't know that, and so went ahead and gave her a benzo.
I just
Can I jump in real quick?
Absolutely.
Yeah, this is Mary Ann Long. I honestly think that you did. I mean, it sounds like you went above and beyond to me, and the fact that you offered her treatment and she declined. I think at some point there does need to be some accountability involved. Otherwise, there's no change in behavior. I don't feel like it's like abandoning the patient. You're not saying, I'm not going to give you Suboxone, but what you're saying is you need more intensive treatment, and you know, she could continue to take benzos, but then maybe, you know, you're seeing her very frequently in clinic, you're having her come in a few times a week, you know, that sort of thing. I feel like you went above and beyond personally.
I would love a game plan for when she comes back in about 3 weeks.
So I think, you know, in some ways this is almost recreating what happens in the family, which is you keep everybody separate and you tell everybody different stuff. And that way nobody talks to each other. And that's one of the things that really can keep addiction very active. So I would certainly recommend that in order for you to work effectively with her, that you need to have contact with her other providers. And you don't know what her other providers will say about, you know, what treatment they're recommending for her versus what treatment you're giving her. But for you guys to be able to talk on the provider to provider level is really important, to get a plan together that is going to benefit her, but everybody has to know what the other one's doing. Otherwise, you could be doing stuff that could be really contraindicated in terms of her overall care. So it sounded like you tried to do that and she refused. But to suggest that again, to give her, you know, more comprehensive care where providers are talking to each other.
Okay. And you're thinking maybe I should make that a part of our agreement when she comes back? Like, in order for us to treat you appropriately, I really need permission to talk to your provider. And if I'm not given that, perhaps this is not the best program.
Well, I mean, instead of that second part, and if you can't do that, this is not the best program. Like, tell me what your fears are about your providers talking to each other, because it seems like that was making you uncomfortable for her, and I just want to understand that a little bit better.
Yeah, she said it. She said her family doctor did not know she was on Suboxone. She had a great relationship with this new provider over the past 2-3 years, and she just didn't want her to look at her as if she was someone with substance use. Well, she's an addict, you know. So she was just scared of losing rapport, which is true, very and legit concern.
Adina, tell her that the minute her doctor wisens up and checks her board of pharmacy, which legally she's supposed to be doing already, she's going to find out she's on Suboxone regardless. So it's kind of a near miracle that the doctor doesn't know already, and it's just a ticking time bomb, because that's the reality of what it is.
Thank you.
You're welcome.
This is Dorothy. I had this happen actually too, where I couldn't get a hold of the primary doc who was prescribing Klonopin while I was prescribing Suboxone, and they were saying, oh, I really like this provider, and I just said, this is like any, like relating it to sort of the stigma thing. This is like any disease, and if you want, like, what is good care is communication between all your providers. But one way I got around this actually was my patient had Medicaid, but I actually kept getting called by pharmacies, like 3 different pharmacies, like freaking out, like, do you know there's this, they have the script for a benzo and you're prescribing Suboxone. And I actually I had to call the pharmacies, and then 2 of them let me cancel the Klonopin from this other provider. I know that's sort of like pharmacy dependent, because some, they only the prescriber can cancel it. But then there was like apparently a flag, because then when the patient went to try and pick up their Suboxone, they said, well, what's with this other script? And they would only actually give her like 2 days until it was resolved. So, for the patient, it was really kind of pain in the butt. But then she was more willing, because she told me, she's like, oh yeah, my primary doc is, on leave right now, but was having a hard time getting, hold of her and stuff like that. But one way that I thought was interesting was just talking to the pharmacy, because they run board of pharmacy, all the time, and they can see all the providers and often send notifications to all the providers that are prescribing controlled substances.
So they could presumably send a notification to the prescriber of the Klonopin in your case, right?
Yeah.
Oh, now that's clever.
Yeah, I hate for people to sort of walk into the pharmacy and have a problem, just because I think pharmacists are not necessarily not always well equipped to deal with an upset patient. But we do have a system in which prescribers of narcotics are supposed to know about what other narcotics people are just prescribing, as people are saying. And so it's very likely that maybe her doctor knows and has not said anything, or, at any time, as Jeremy was saying, at any time, could run a board of pharmacy and know.
If I could make a quick comment as a pharmacist who has been in those situations, oftentimes we're ill-equipped to handle the situation because we don't have all the information. We don't even have access to a diagnosis code. And we often have to guess about why a patient's being treated for what. And the best tool we have is prescription drug monitoring program and NARCS care, which gives us some information, but without context. So to the degree that pharmacists and prescribers and behavioral health specialists can collaborate, pharmacists can be a lot better at helping you manage your patients.
And just so everybody knows, you can attach diagnosis codes to medicines, and I really encourage everybody to do so. Naltrexone, you have to have alcohol or opioid use disorder as a diagnosis code. So for every Suboxone person, I'll put like use disorder, in early remission, or sustained remission, and that hopefully does color the context a little bit. But everybody should be in the habit of doing that if you can with your EMR. So.
Yeah, I appreciate that, Thomas. That's really helpful, kind of to know the pharmacist's perspective as well. Thank you.
And Dr. Reynolds, I'm not sure if I saw you unmute or not, but wanted to give you a chance to chime in.
Can you hear me?
Yes.
Yeah.
Okay, my microphone wasn't working earlier, so I thought I'd say quiet.
Your square is all black, but we can hear you.
Just like my heart. Adina, I think the situation you were presented with was not ideal, and so I'm sure there were a lot of ways to handle it. But I thought what you did was incredibly clever, because this woman was not going to get honest. She had all the information sitting her in the face, and you talk to her and you explain who you are and what you're trying to do, and she was not going to get honest. And you sort of manufactured a situation where she got, quote, caught and had to face the fact that she was being dishonest, which, that can be, I think that could be a real turning moment for somebody, you know, to have that kind of pointed out so that she actually had to face it. And the truth is that if she wasn't going to get honest, I mean, I don't know how well she would have done moving forward. So, I mean, I'm sure there were other perspectives on it, but I thought it was pretty clever.
Thank you all so much for this great discussion. Laura, were you going to say something? Sorry if I cut you off.
No, just in response to what Mike was saying. Yeah, I mean, the reason that people change their behavior is because of consequences. And if it becomes, you know, too uncomfortable to continue the way you're going, people then look to make a change. Not that we need to force consequences as providers, but creating, you know, natural consequences, which are when your doctors are not talking to each other, it can create some problems with regard to giving the best care. And so, yeah, just echoing that consequences aren't necessarily bad. They often bring about change that patients choose themselves.
Thank you so much, Laura. But we do actually have just about 2 minutes left. I don't want to cut anyone off from this great discussion, but we do actually have another meeting right after this. So I want to give them enough time to be able to log in and everything. But if there are any further conversation items or discussion items that you want to continue, please email them to me. I'll make sure that a conversation continues because this has been so wonderful. Dr. Bo, thank you so much for that informal case. It really sparked some great discussion. Yeah, and just appreciate you all, you know, chiming in and giving your perspectives. So thank you for that. And as always, thank you, Laura, as well for the excellent didactic. I'll make sure you have all the items sent to me so I can distribute it to the group. The only announcement that I have is that the next session will be on October 10th and Olivia Hickton will be presenting on communication methods. Thank you all so much. I hope you have a great evening and we'll see you next time. Bye, guys.